And thank you for listening to me in my mother tongue and tolerating that. We're filming this morning, so I'm going to sort of stand here in a rather formal way to make sure that that is done effectively. So I apologise for the formality. You've heard from Jean-Louis what I'd like to speak about, talk about our role at the King's Fund. Let me start with my own experience. I have had a career over about 40 years as a health service researcher, interested in the relationship between research and policy making, mainly working, as Jean-Louis has said, at the University of Birmingham, but also at other universities at different points. I spent over 4 years working in government. I was the Director of Strategy in the Department of Health between the year 2000 and 2004. So, as I like to say, I'm a recovering civil servant from the time I was there. And I've worked twice at the King's Fund, most recently in my current role for the last 6 years, but previously at the end of the 1980s and the beginning of the 1990s. So I bring a variety of experience to this topic today. I want to start with a statement of the obvious, the very different worlds and the environments of researchers and policymakers. Different timescales. Often researchers are working over a much longer timescale than policymakers. Certainly when I worked in the Department of Health, the timescales were sometimes in hours or days rather than months and years. And the transition from being a researcher into being a policymaker was quite a hard one to make to accommodate that. Languages vary. Researchers have their own jargon, their own specialist language, which doesn't communicate well very often to policymakers who don't understand that language. The incentives differ. So in the UK, I don't know if it's the same here in Quebec, the incentives for researchers are to research and publish in high-quality, peer-reviewed, international academic journals, typically read by their peers in their specialist subject. And those journals, by definition almost, are not read by policymakers and decision makers. Decision makers want practical, usable information very quickly around the short timescales. And then, what counts as evidence? Evidence for researchers means one thing. Evidence for policymakers sometimes, not always, means a different thing. Rudolf Klein is somebody who I've looked up to throughout my career, an eminent health policy analyst and researcher at the University of Bath, the LSE, and for a time at the King's Fund too. Incidentally, Rudolf spent a lot of his career as a journalist, writing for the broadsheet newspapers in the UK about a variety of social policy issues. He came to academic research quite late in his career, and he had this to say. I'm not going to read it through. I'll give you credit for reading the quote here. What he says about evidence, and from a policymaker point of view, more about practical wisdom or judgment rather than perhaps research-based evidence that comes out of evaluations and studies and trials of different kinds. That certainly rings true to me, having straddled these two worlds myself. Also, policy making and politics are inseparable in my experience. So policy making very often is not a scientific or a logical process. I would say policy is a soup which is made up of many different ingredients. It's probably a minestrone soup or whatever your preference might be. And you could argue that evidence-based policy is a contradiction in terms for the reasons I've set out here. Politicians, one kind of policymaker, bring their own values, their own ideologies, depending on where they sit on the political spectrum. Nothing wrong with that. That's what politics is all about. It's an argument, a debate about different value systems and different ideologies. And evidence defined in research terms doesn't fit easily and into an environment where values play a significant part. Just to be topical about this, at the moment we're having quite a debate in England about different ways of tackling obesity and overweight in the population, and accumulating evidence about the impact of sugar in food and drinks and the impact that is having on rates of obesity and overweight. And you might argue, but you might argue differently, of course, there is accumulating evidence to suggest that now is the time for government intervention, legislation or perhaps changes in pricing policy that would deter people from consuming foods and drinks high in added sugar content. And there's been a big review on that by Public Health England, which is the national body responsible for looking at the expert evidence around things like sugar in diet and sugar in drinks. And that's a good illustration of how the evidence might point in one direction in favour of higher taxes on sugary foods, whereas the ideology of our current government, a Conservative government, would argue against that, a government concerned to be seen as part of the nanny state, telling people what to do, putting extra prices onto foods that are high in sugar content, rather than letting people make their own choices, a more libertarian position. And that debate was played out too a decade or so ago when we had the discussion about smoking control and moving to smoke-free environments, which took a long time to work through until eventually the Labour government of the day did legislate on that particular issue with beneficial impact, as we now know, for the public health. But that concern about restricting people's liberties and freedoms to take their own choices was very powerful until the point came when legislation was possible. Let me talk a bit about push and pull. Speaking as a sometime researcher, I would say it's relatively unusual in my country for researchers to want to push their evidence into the policy-making process. I don't know if that's the same here in Quebec. And it varies, of course, but very often the researchers I used to work with in university settings, they felt their job had been done when their evaluations and studies had been completed. They'd written their research reports. They then converted research reports into articles for peer-reviewed journals. And they were moving on to the next study and the next evaluation. It wasn't their job, as they saw it, to convert their evidence into something that was usable and could influence politicians or policymakers in health departments or indeed in hospitals and other healthcare organisations. And on the other side, the incentive or the willingness of policymakers of different kinds to pull in research evidence to support their decisions is often weak. Sometimes it can be very strong. If there is a major public health concern, like Ebola, for example, in those circumstances it's different. But in many of the other areas, such as the public health examples I've given, in England, I would say the incentive for policymakers to know about the evidence and act on the evidence is variable and often weak. And that's where translators come in, or knowledge brokers, people who can help bridge the worlds of researchers and the worlds of policymakers. So, who are these people? Well, I'd suggest from my experience there are a number of different examples of translators. They can include public officials, civil servants working, say, in government departments who are closely connected to researchers, who can commission the right researchers to access research and evidence. And we have some good examples of that back home. A team of people in our health department in London that I worked with who are well connected into the health service research community and can act as a bridge or broker between the policymakers who have a question and the researchers who may be able to produce evidence and some answers to that question. So that's one category. A second category are the applied health service researchers who can be commissioned and receive research grants from government to carry out research on policy issues. And this is, again, something that we have a lot of experience of. We have health economics research units at the University of York, for example, a big team there who rely a great deal on government funding to support a programme of research over years. We have primary care researchers equally funded in the same way. We have public health researchers. So a lot of the research funding comes through government sources and is intended, by definition, to address policy problems. And then we have organisations like my own, the King's Fund. We occupy this middle ground too. We are brokers between the two communities. One of the dilemmas here, perhaps, for researchers is wanting, in some cases, not all cases, to use their evidence to influence policy making, to have a practical impact on decisions, but not to have their independence, their integrity compromised in the process. I think it is possible to do both, but I know some research colleagues will be quite concerned to accept government funding because there may be strings attached which might be unacceptable around the important independence that they bring to their work. Jean-Louis asked me to speak today about the King's Fund, so just a few words about the fund, our history, where we come from. King's Fund originated in 1897, not, by the way, doing the work we do today. That's more recent in its evolution and its origins. It was established originally to raise funds for the hospitals at the time, before we had a publicly funded National Health Service. And the Prince of Wales, Prince Edward, raised money from the aristocracy, which was then funneled and channeled into the voluntary hospitals that needed funding in London in particular. So the modern King's Fund was established when the National Health Service was set up in 1948. An endowment had been built up, an endowment of funds over the years invested in stocks and shares and other sources. It brings in an annual income, and that then supports part of the work of the King's Fund today. So we have our own independent funding source through our endowment. We're very fortunate to have that, and I recognise that we're relatively unusual. We do carry out research and analysis. We're seen, because of our independence, as a trusted source of information in an area where there is lively debate about what's really going on and who's in a position to tell the truth about what's going on. Most of our research is not original and primary research. We synthesize and we summarize what university researchers and others are able to do. And most of our work is about the organisation of care and how care is funded. We don't do work on clinical care. We do work on public health, and I'll talk more about that if that's of interest. But primarily, we use our expertise to comment on and advise on how care should be organised, how it should be funded, how it might be improved. And as well as our endowment, we do undertake some externally funded work, so we can carry out more than we're able to simply with our own resources. This is just a slide of our website. You can access that and download freely all of the publications and the blogs and the other resources that we make available on the website. So, how do we work? We have a policy team of around about 20 people. They come from different backgrounds. Some, like myself, come from a university academic research background. Some have worked within the health sector, in the health department, in the government, and within hospitals or healthcare organisations. Every year we produce a range of policy documents, about 30 major policy reports. These are the ones you can find on the website. We also produce shorter briefings, we produce lots of blogs, we produce other outputs, sense-making outputs as we call them, helping the leaders in the sector to make sense of what really is going on around funding and organisation and reform. And the point I want to emphasise is the impact we have, whatever that might be, depends not just on this policy team, it depends crucially on our communications team. And I want to say a few words about the communications team because they are critical in disseminating the work we do, helping our work to reach the right audiences in the hope that it will reach those audiences at the right time to feed into deliberations about policy and the decisions that are taken. So this may surprise you. Our communications team is about the same size as our policy team, about 20 people. And they do a number of things. So they edit and produce our publications, we think, to a high standard. They're very innovative. They produce digital reports as well as our ordinary, straightforward reports. They maintain our website, which is a window into the work we do. They maintain our presence. So we use Twitter, particularly, to communicate what we do. We use Facebook, we use a variety of new media, social media, to get our message across, if you like, more in sound bites. 4 members of the team focus on press and public affairs. So they're the colleagues that we look to. When we have a report coming out, as we did this week, it's a report on the state of finances and performance within the English NHS. That team will have been working for about a month leading up to the publication of the report, phoning journalists, making sure that the press and the media are briefed. These are the national newspapers, and this week I think our report got covered in about 8 of our national newspapers. The specialist press, the British Medical Journal, the Health Service Journal, TV and radio. One of my colleagues spent quite a lot of Thursday morning going around the TV and radio studios being interviewed about the report that we published. And that wouldn't happen if we just had a policy team. It happens because we've got a communications team, and a communications team who know how to get our message across. And that's a very important part of who we are and what we do. Because some of our policy team, like the researchers I was talking about earlier on, believe their job has been done when they've written the report and the report goes up on the website. And to a large extent, they have. But if we got people supporting them to fix the opportunities to talk on public radio or on the BBC News or do other things of that kind, then they will do that because that's part of what we do at the fund. We have an events team of 4 people who plan a programme of seminars and conferences. Some are open, some more by invitation, so we can get our message across in those forums to the relevant people we're trying to reach. So the communications team is really critical to the work we do at the fund. This is what we call our logic model, which helps to explain the way in which we try and work. We didn't start with a logic model and then did our work. We did our work and realised there was a logic model behind it. So this is retrofitting the logic model to the work once the work had been done. I make no apology for that because, well, yeah, it was emergent rather than something we spent a lot of time thinking of. So we try to build the evidence base in the way that our policy team works, summarising, synthesising a lot of the work that's already out there. We bring that together in publications and other outputs, and we try and use that then to influence national leaders and local leaders. I'll come back and talk more about how we do that. Let's assume that on some occasions that evidence really does have some influence. Most of the time it probably doesn't, but some of the time it certainly does. I'll give you an example in a minute. We then have a team within the fund, separate from the policy team, separate from the communications team, that's involved in leadership and organisational development and promoting innovations in care. That team will be involved in supporting implementation. And in doing that, we're learning about what works and what doesn't work. And I'll give this as a concrete example in a minute. And that can then feed back into the evidence base at the beginning. It sounds neat and logical. It's much messier in practice. But, you know, as a heuristic, as a framework, as a way of thinking about these issues, that's something we've learnt about how we work in practice, how we can describe it and share it with others. So let me make this more concrete. In England, as in Quebec and many other jurisdictions, there's growing interest in how it's possible to put in place care models that are much more integrated between primary and secondary care, health and social care, physical and mental health services. I've been working on this myself for over 20 years. For most of that time in England, it's felt like being a voice in the wilderness because the decision makers and the policy makers haven't wanted to listen to and hear about integrated care, but recently they have. So for the last 6 years at the King's Fund, this has been a high priority. We published a lot of reports setting out the evidence and the arguments why integrated care is important. We've then used those reports to shape and influence government policy. We've then worked with a number of areas, demonstration projects in different areas of England who've wanted to implement more integration of care. And we've learned in the process, we've gathered intelligence about the impact, and we fed that back into the evidence base, and we've exerted further influence. Where this works, there's a virtuous circle from the beginning until the end, and you continue building the evidence base as a consequence. So how do we work with policymakers? Here I'm talking about politicians in government at a national level. I'm talking about senior public officials and civil servants. Well, we do it both publicly and privately. In public, I've talked about our reports, our use of radio and television, and of other media. We're fortunate to have 5 or 6 senior people within the King's Fund who are all credible communicators. Absolutely professional when it means going on to live television or radio and talking to journalists, and not being shy about doing that, being confident about doing that because they have a lot of experience. But working in private is very important too. So meetings with the health ministers, meeting with senior public officials on a regular basis, because this is about a contact sport. It is about having access and being able to talk face-to-face from time to time with the health minister or with the people advising the health minister or the special political advisors that our ministers also rely on. We're fortunate, and I know this is not common, to have regular and good access to these key decision makers, but it varies. It doesn't vary depending on who the party in power is. It varies more on the basis of personalities. So at the moment, we have good access to our current health minister. The previous one, it wasn't so good. The previous health minister had very clear ideas as to what he wanted to do, and he thought about it for a long time, and he wasn't very much interested in hearing what other people had to say. Our current health minister didn't have a lot of time. He had no background in health policy, and he was actually quite hungry to hear what people had to say. Didn't always accept outside points of view. Why should he? But it meant that we've had a very different kind of access with him than with his predecessor. And there is a balance here, because if we're very critical in public, of course it may impact on our ability to get private access to the people we're criticising. So I could talk more about how we judge the balance between the two, and it is a matter of judgment. We also work with healthcare leaders. Here I'm talking about people at a regional level or at a hospital local service delivery level. We communicate with them through face-to-face meetings, events, emails, a variety of channels. And when we produce a policy report, we're often trying to draw out, what does it mean if I'm a chief executive of a teaching hospital, or the leader of a mental health unit, or running an integrated service for older people in some part of England? What we want is to write a report where they will read it and say, yes, there's something in this for us. It's not just targeted at the national policymakers. It's making recommendations and giving us ideas that we can use and we can act on in practice. We are a small organisation, so I don't want to exaggerate how much of that we're able to do, but we do speak to Whitehall and Westminster, but we speak to people in those regional and local roles too. Whatever influence we have, whatever impact we're able to have, depends on the knowledge we have of how policymakers work and how healthcare leaders work. So, as I've said, the people who make up our policy team come from a variety of backgrounds. A number of them have worked in the Department of Health. They bring a lot of understanding and networks with them to help us set up the meetings and the opportunities we have. Others have worked in senior roles within the healthcare system and in local government. Yet others know very well how the media works, how to get the message across to the journalists who may report what we have to say. So it's inside knowledge which we're able to draw on, which helps us to make a difference. And from time to time, the government will come to us and say, will you undertake a commission? Sometimes it's paid, sometimes it's unpaid, on a project that we can't do ourselves. If I can just give you one example, this happened in the second half of last year. The health minister came to us and said, we want you to advise us on how we as government should assess the performance of our local health systems. They approached us in June, we took the commission on in July, and our deadline was to report at the end of September. They actually asked us to delay publication even though the work had been completed until the 12th of October, so we published within about 3 months of the work starting. The report challenged a lot of the assumptions made. I won't go into detail, but essentially our health minister pretty much knew what he wanted to do, and I think he hoped by commissioning us it would give some legitimacy to the answer he'd already formulated in his mind. It wasn't quite as simple as that because we didn't think it was the right answer, and we said so very directly and clearly in our report. We didn't receive or seek funding for doing this. We did it with our own resources. So there was no risk at all that we would be told, you've been paid to do this work, you need to alter your conclusions. Not that we would do that anyway, let me reassure you, but absolutely not in this case. And it got tricky. Towards the end of the process, as we were completing our report, I won't go into the gory detail, but there was a lot of toing and froing between myself and colleagues who were writing the report and the minister's staff, who realised we weren't going to deliver what he hoped, and were on the phone on a pretty regular basis trying to explain why a different report would be more acceptable to the minister. We resisted the attempt to influence us in that way. As Jean-Louis said, this is about speaking truth to power, even when power may not want to hear the truth. And that's pretty important. This is the report we published. Again, you'll find this on our website. And having said what we said in this report, it's quite difficult now for the minister just to plough on with what he wants to do, because once you commission an independent assessment, then it constrains your freedom to make your own decisions independently. Let me use the last 5 minutes or so just to bring some of these strands together. Networks are very important. We often say the fund has a convening role. We bring people together from different organisations. We're fortunate to have a wonderful building in the heart of central London, which has conference and meeting facilities. It has a library, it has our own offices, it has a cafe that's open to anybody who wants to walk in and use the cafe and to meet with us and with others. So we have a building which is very conducive to us being a meeting place. It's a forum where people come together from all over the healthcare system. We have great networks with policymakers, researchers, with others. We have an international focus to our work. We have a number of international visiting fellows who spend some time with us, bringing experience from other parts of the world. And even when they're not with us, we know where they live. So we're able to email and phone and seek advice and access their research and their evidence and their intelligence. So in an informal way, this is about the wisdom of the crowd. 20 people amplified by a much bigger network that we're able to draw on in that way. Let me come back to the messiness. I don't want you to leave this session to think that logic model is how it all works, because that logic model applies in a very small proportion. of our activity. It is a stylized description of a much more complex reality, a much messier reality. From my experience, policy making is not an event, it's a process. It's an iterative process. It's like a game of snakes and ladders. Sometimes you make progress, but then you slide down and you're back to where you started again. I would say research very often involves this accumulation of different kinds of evidence rather than a particular study designed to influence a particular decision. Just in time is important. Policymakers need to know at that moment when they're approaching decisions or options, what is the evidence that we can draw on that might help us to make a better decision informed by the evidence. And they need help in doing that because your health minister or the senior officials won't know where the evidence is. But if they have brokers in their health department, they might be able to do so. And of course, I've said on some issues, perhaps on many issues, research-based evidence may be lacking, may be contested, certainly will be incomplete. And research-based evidence shouldn't trump other kinds of evidence, going back to what Rudolf Klein had to say. I would say the influence we have, such as it is often about this sense-making. It's about shaping the public debate about health policy. It's not the one-to-one relationship between research on the one hand, decision on the other. It's about helping to frame the discussion that's taking place about organisation, funding and reform. A senior public official said to me not long after I took up post, he said, King's Fund's important because you make the weather in healthcare. And that's partly what I'm talking about here. That's partly why we get access, because we're taken seriously because we're weather makers. We have some influence over the terms of the debate. And that's exemplified at the moment by the work we've been doing on the funding of healthcare and the performance of the NHS. The report I mentioned that came out this week on the state of finances and the state of performance, it's a quarterly report. We set this up 5 years ago. And now, of course, because it's a quarterly report, people who are interested in funding and performance know when the next one's about to come out. So I continue to get phone calls from senior decision makers saying, and when is the next one coming out? And what's it going to say? And how bad is it going to be? You know, it is like an optimism-pessimism index, but actually pessimism is the order of the day at the moment. This is a quote I'll leave you to have a look at. So, as with any good paper, limitations. Yeah. And I don't want to overclaim for anything we do. At the end of the day, we're a small organisation, certainly compared with the size of the healthcare system we're trying to influence and have an impact on. You can see the numbers there. Whatever influence we have comes from the quality of our work. Is it rigorous? Is it relevant? Is it timely? It's a cliche, but it's true. We are only as good as our people and their skills in working in this way. There are a lot of people we'd like to have working with us, but they prefer to be in universities, or they prefer to be in government departments, or they prefer to be out there trying to make a difference within a hospital or a healthcare setting. And that's fine. We just need 20 good people to do the policy work and 20 good people to do the comms work, and then we're in reasonably good shape. The networks are very important to us. And if I'm self-critical, and this is me as much as anybody else, we try to do too much and perhaps our message and our impact is diluted because we're trying to cover too much of the waterfront. And some of the good work we do may get lost because of the noise from the fund. The noise and the signal have to be distinguished very, very clearly. So we know we can do better, and we know that that's something we have to work on. We face risks. When I talk to people about the fund, when they just join us as part of their induction, the thing I emphasise more than anything else is our independence and the rigour also that we bring to our work. Independence means we're not aligned politically. We don't support any of the political parties. We use our expertise to offer, well, to speak truth to power, to use the shorthand. And if there's any sense we were on the left, on the right, or somewhere else, then that would be a concern. Reputational damage would equally come from doing work of a poor standard. So we have quite strong QA processes internally to hopefully avoid that happening, and touch wood, it's not happened on my watch. We have very well-informed experts in the fund, but what people listen to out there is the views of the King's Fund. And this is very different in my experience from working in a university, because when I worked at the University of Birmingham, people weren't expecting there to be a corporate view from the University of Birmingham. They looked to the experts, the named people they went to, if they were journalists, to speak about the issues of the day. That is not the case in the fund. So we don't stifle individual expertise and views, but we harness those around the views of the fund. It's that corporate perspective which is very important. And in a world of Twitter and new media, there's always the risk at 11 o'clock at night somebody might send out an indiscreet tweet, and that could cause reputational damage too, around our independence or the quality and rigour of our work. So we have our code of conduct around the use of new media. This shouldn't sound, I hope, as if we're absolutely controlling and limiting what people do. We rely on their judgment. So we hire on the basis of our confidence in the ability of people to work in this way, playing to their strengths about being part of a team. So these are the key messages in summary. I'll leave those there for you to have a look at, and thank you very much for listening.